I'm Phaik Yeong Cheah. I'm a professor of global health at University of Oxford. I'm also the head of Bioethics and Engagement at the Mahidol Oxford Tropical Medicine Research Unit based in Bangkok. To me, global health research is any research that aims to advance health inequities between communities and within communities. To make the most impact, global health researchers should focus on communities with health challenges, the worst health challenges. We should focus on communities that are the worst off in terms of health. So I would like to make a distinction between equity and equality. Equality means treating everybody the same. Equity means recognizing that people have different starting points, have different needs, and this could be due to structural challenges. And this means that we need to pay attention to this and to recognize that there are existing health inequalities. I think in global health research, the first and most important thing, I think, is to understand equity in a given context. In some places, health inequalities are caused by difference in, let's say, ethnicity or difference in gender. But there are also other important factors like on the Thai-Myanmar border where I work, migrants who come from Myanmar to Thailand, their main challenge is lack of documentation. And lack of documentation means it is difficult for them to access health care in the Thai setting. So that would be one source of health inequalities on the Thai-Myanmar border. So once a researcher understands the issues that affect health inequities in a certain context, there are a few things researchers can do. I think the first thing is about the research question. So as I said, global health, for me, by definition, is working with these populations who are the worst off. But even within that context, choosing what to study or health priority setting is actually really important. So the priority setting should involve various levels of stakeholders. That includes local researchers, local healthcare workers, and local communities, because we need their input to ensure that we're asking the right questions, the questions that would give us answers that we can use to advance health equity in a given context. Secondly, it's about community engagement. So community engagement is helpful in defining research priorities, but it's also important throughout the whole research journey. So priority setting, implementation, up to research dissemination. And with engagement, we can understand how to conduct research the most ethical and effective way possible in a given community. And I want to also make a point that community engagement involves getting views from communities who could be the worst off. And in addition to convenient communities, they might live very far away. They might not speak the language, but we should make an effort to make their voices heard. We could use innovative methods. In my work, we have worked with community advisory boards for a long time. So because these members of community advisory boards, they know us very well. They can tell us things that we wouldn't otherwise hear. They can be honest with us. So if we want to say, we want to conduct X research in this population, they can say, oh well, you should change it to this way, or they say no, that wouldn't go well in our community. So the other thing is about participants in research. So research participants who who are recruited into studies. So we all sometimes know of studies where the study population, the study sample, it's not really representative of the population that the data is meant to help. So we should also, in terms of equity, we should also ensure that community members or people who want to participate in studies are given the opportunities to. And sometimes these barriers are not because of, it's not by because of their own fault. It's because researchers don't make enough effort to reach them. One example that is obvious is making research materials accessible to communities whom we want to participate, and making sure that, let's say, the study center is accessible to the communities whom you want to recruit from. And I would like to also say, sometimes if you look at the protocol, it has got eligibility criteria, and usually, of course, in clinical trials, the eligibility criteria is there for a reason. So you have the formal eligibility criteria, but actually there are informal eligibility criteria, which can be people who live very far away. They can't actually reach the study site. So you would have this informal eligibility criteria. One example I can give from my work, so this is in northern Thailand, where we work with many hill tribe communities. So they, example is people from the Lahu and Hmong hill tribe group. They don't even have written languages. So when your consent materials are in English or Thai for that matter, then they will not be able to participate in your study, although the study is designed to help that community. So we work with our community advisory board there to make sure that our consent materials are accessible to this community, and we have interpreters to help with recruitment. One other thing I think is important is research. Our research methods. Our research methods could be making sure that our data collection tools collect meaningful data that could give us meaningful disaggregated data. Sometimes that means sex, sometimes that means ethnicity, sometimes that means other factors. It's important for the disease in question. And last but not least is the teams, equity in teams. Equity in teams serve, well, at least two functions. One is it is the right thing to do, and the other is to achieve all the dimensions of equity that I mentioned just now. In the teams, you need a diverse and inclusive team to make sure that we ask the right questions, we analyze the data appropriately, meaningfully. So global health researchers have their own limitations in terms of experience, in terms of expertise, in terms of funding, in terms of, so many limitations. So yes, of course, I said just now we should talk to communities and key local stakeholders, but we must know how to ask the question and not raise expectations. Because if you ask a question and they say, okay, I would like you to do work on X and your expertise is Y. So we don't want to raise unrealistic expectations, because that in itself is an ethical issue. And we all have funding limitations. We all have expertise limitations. You need skillful facilitators to ask the right questions so that people whom you ask understand what you're trying to do. But I think this is a key step in trying to get what the most important health challenges are, and so that we can ask the right questions. One example I'd like to share is our work on the Thai-Myanmar border. So this is in northwestern Thailand, and it borders with Myanmar. So there's quite a lot of migrants who come over from Myanmar to Thailand to seek medical care. So traditionally, if you look at research ethics guidelines, these communities will be considered vulnerable. And being vulnerable, ethics committees, for instance, will set a high bar on conducting research with these populations because there's a fear of exploitation. But what we found is when we talk to our research participants who are pregnant women who had malaria, they really enjoyed being participants. They wanted to participate because they want to share their experiences with other pregnant women who have malaria. They also enjoyed meeting researchers and talking to them and know about malaria. Yes, they are very vulnerable in the sense that they don't speak Thai and they don't have formal education, but still they can make decisions to participate in studies. So from that work, we learned so much from it because we know that participants enjoy and benefit a lot from being from participating in studies. We ensured that their participation doesn't, for example, overburden them. We provided transportation. We reimburse for transportation if we can't provide the transportation. We ensure that visits to clinics are not that frequent because they actually live very far away. So they would spend all day coming to the clinic and all day going back. So they actually miss a day's work. And sometimes they have child caring responsibilities. They have to bring their children with them. So the point I'm trying to make is, yes, it is really, really challenging to recruit some communities, but as researchers, there is so much we can do to improve our participant population. One strategy is what some researchers call decentralized trials. Decentralized trials just means that there's no central location where a trial is conducted. So trials could be, or recruitment could occur in village settings, in primary healthcare centers, in the villages. So these are decentralized places for recruitment so that participants don't have to travel to the central recruitment center. And there are clever tools that people can use. One is apps. One is sample collection kits. So these are things that people can do to make sure that we improve the participation from communities that are often not even invited to participate in research. I think it is just science should be available to everyone. So researchers should have a responsibility to make sure that communities are offered participation. If they want to participate in the trial, they should be able to. In my own work, we have done a few things. One is to improve our consent materials to ensure that participants it is accessible. Language is in the language of participants, and this could mean we consult with our community advisory boards, and they advise us on the correct terminology to use. And they also help us with illustrations. And in communities that don't have written languages, we have trained interpreters, so they work with us. So they are employed by us, and they train. They understand all the scientific words, and they would use that when they talk to participants. Now, this is really important because we found in our qualitative study in northern Thailand, that participants would come with a family member who can speak Thai, but actually that family member doesn't translate very accurately, and which means that the consent session is not quite right. So we train our own interpreters now. The other strategy is to ensure that participants don't be out of pocket when it comes to expenses. So we make sure we either provide transport where possible, or in certain cases we go to their homes, and if that's not possible, then they take their own transport and we reimburse them for transport fees. But that's not the only thing. If they come to the clinic, they will lose a day's wages. And sometimes they also have child caring responsibilities. So we just want make sure that we compensate for the day's wages, for example, and encourage them to, okay, if you want to bring your child to the clinic, you can, there will be facilities for you